most of you are especially in more the beginning stage of looking at using the National Healthcare Safety Network database. I titled this presentation Symptoms Matter because when you're looking at urinary tract infections, it really does. I've been working with the National Healthcare Safety Network for 10 years now on a regular basis. And so I had an opportunity that I hope I can share with you some tips and tricks to help know what you can do going forward in using it. So our objectives for today are to look at the NHSN, or the National Healthcare Safety Network database, surveillance definitions. And I think it's always important to remember when you're doing surveillance as an infection preventionist that you realize that if something meets the surveillance definition, the clinical picture, it may not. So it may be an infection and not meet the surveillance definition, and it may meet the surveillance definition and it not actually be an infection. So I think we need to always be aware of that. We're going to look at the different classifications of the different CAUTI definitions. And also we're going to look at how you tell of an infection if somebody's transferred or discharged from your facility, and do some practice, I think, which helps more than anything when we're talking about CAUTI definitions. So first of all, I think we have to look at what do you have to have in order to say that something is a catheter-associated urinary tract infection. These are the first three things that have to be present before you can go any further with that. There has to be a catheter, and that catheter has to go through the urethra. It has to be left in place, so it's not going to be an in and out catheter, and it has to be connected to a drainage bag. And so that's why a condom catheter doesn't work, because it isn't a catheter through the urethra. In and out aren't attached to a drainage bag. And this also does not include suprapubic catheters either. And when we talk about a catheter, what is a catheter? But I think we all know that. And it's important that you get the terminology that NHSN uses. You won't see the word Foley anywhere in their protocol manuals. They will call it an indwelling urinary catheter, and they will abbreviate that as an IUC. The catheter, or the Foley catheter, was invented in 1935 by Dr. Frederick Foley, and the slides are not moving forward. Is that still the case, Dana? I'll just do a check here. I just saw your text.
Yes, that is still the case. We see your initial slide, and so maybe put it into slideshow and see if that.
It is on slideshow. So, oh, I wonder, are you seeing two slides or one slide?
We're just seeing one. It kind of just looks like you pulled just in PowerPoint. It just looks like it's pulled up in PowerPoint and not in slideshow version right now.
It is in slideshow. Let's see, let's try this. Did that make a difference?
Yes, now we see the must-haves for CAUTI. Is that what
great? Great. Okay.
Is anybody having problems with the sound? Can everyone hear? Okay.
Okay, I'll take that as a yes. And I'm just going to go back here just a minute, just so that you did catch in, because I think it's really important. We have to get these must-haves down as in our minds, first of all, in order to go forward as beginning information. We have to have a catheter through the urethra that's left in place, connected to a drainage bag. And in the NHSN information, it calls them an indwelling urinary catheter, not what we're used to as a Foley catheter. It's kind of fun history, and I've always been kind of a history buff. Dr. Frederick Foley invented the Foley catheter in 1935 after the invention of a wonderful thing called rubber by Charles Goodyear. So that's how it came about, and I'm sure you recognize the name of Charles Goodyear. So that catheter that is in through the urethra, left in place, connected to a drainage bag, has to be in place for more than 2 days in order for it to be a catheter-associated UTI. So the patient has to have exposure to that catheter enough that it makes a difference in it being a causative agent in the infection. And the device insertion is considered day 1. So the first day, the next day after, and so the third day is when you can look at whether it is a catheter-associated urinary tract infection, or admit date if it's present when the patient came into the hospital or into your facility. And then the third thing that has to be, which is a must-have, is there has to be a positive urine infection. Positive urine culture. So looking at that in place for greater than 2 days, let's make sure that we're counting urinary catheter days correctly. And that's part of the measurement for measuring whether something is a urinary tract infection, is you have to have a denominator to it. And so you have to count all the urinary catheter days in each of your locations every day and then add them up by the month. They should be counted at the same time each day, and the number of patients have to be separated into their different units by the locations that you have divided your facility up to in setting up your NHSN database. And you only count the number of patients with an indwelling urinary catheter. NHSN has a nice worksheet in order to keep track of this if you do it manually. If you do it electronically, you need to validate it for 3 months to make sure that your electronic method is actually capturing all your urinary catheter days. And you need to do that for at least 3 months. If you find the difference between your manual method and your electronic method is within 5% of each other, then you can go forward with that electronic method. I know and then you need to do this again. I've heard some places lately that are getting a new electronic medical record. You need to then validate those if you change electronic medical records too. So this is simply a picture of what the worksheet that's available for you in the NHSN website that you can use in order to count urinary catheter days. And remember, it has to be by each separate location. You have to then enter that denominator data or that beginning summary data every month into the database. And this is a screenshot of where you do that at. You enter the summary data and you put in how many patient days you had on that location, and you enter in how many urinary catheter days that you had in that location. And then this is also the opportunity to put in your numerator too. So if you click in this box right here, if you do not have any infections that month, then you've done all your reporting. Now, most of you are probably too small. You see the box next to it that talks about sampling data. I'm not going to go over that today because you really have to have a large facility in order to have enough urinary catheter days in order to use sampling. And I can tell you, so many of you have been so good about getting the catheter out. A lot of times catheter days are pretty low anyway. So remember, the third must-have we have to have is a positive urine culture. What is a positive urine culture to be used as part of the surveillance definition? It has to be only bacteria as the causative agent. So it can't be yeast, or another word for yeast is candida. Can't be mold, it can't be parasites, it can't be anything else in that urine other than a bacteria. An important point is it has to be on the uropathogen list, and we're going to look at that here shortly. And it has to be enough of the bacteria in order for it to be of an amount that is significant, that would be called an infection. It has to be greater to or equal to 100,000 colony-forming units per milliliter, or it's a lot of times abbreviated as 10 to the fifth. And you can see that fifth, there's 5 zeros in that 100,000, and so they mean the same thing. And so your lab needs to report it out as greater than or equal to 100,000 colony-forming units. You do not use a urinalysis in the definition of a catheter-associated urinary tract infection. So I mentioned that it has to be a bacteria. It can't just be a bacteria. It has to be a bacteria that is on the uropathogen list. So the uropathogen list is on the NHSN website, that even if you aren't reporting to NHSN, you can get to all this information just the same. I've got the link up there, cdc.gov/NHSN, and then if you're acute care hospital, and then you look in the CAUTI section. So each of the catheters, so each of the measures in NHSN, the page looks exactly the same. It has this section right here, resources for NHSN users already enrolled. And you would want to go to supporting material and click on this link right here. This will bring up this part of the slide right here that I'm showing you. And under that section is one that says NHSN organism list, all organisms, common commensals, MBI organisms, and UTI bacteria. So you click on that link and it opens up a great big Excel spreadsheet, which is what I have at the bottom of the slide here. And at the bottom of the slide, that great big Excel spreadsheet, the tabs on the worksheet, one of those says UTI bacteria. It needs to be on that listing. That if it's on the list, then it is a uropathogen, and it is one that can be considered so long as it is of an amount of at least 100,000 colony forming units. Okay, what are some other criteria that has to happen? There's someone that I'm hearing a lot of background noise that I think we need to mute. Thank you. No more than 2 species of microorganisms is the other criteria for the culture. Urine cultures with more than 2 organisms are considered contaminated and are not used for clinical care. So if you get back a culture that says mixed flora or there's 3 organisms listed, it cannot be used. Now let's qualify that and make sure we understand what each organism is counted as. An organism of the same genus but 2 different species are considered 2 separate organisms. So we know that bacteria, there's a lot of bacteria in what is considered the same family. So there's a lot of Pseudomonas bacteria out there in that family, just like there's a lot of Gilberts out there in the world. However, specifically, we divide those families down to more individual parts. And so we have a genus and a species. And so Pseudomonas aeruginosa is specifically a bacteria, just like Gilbert is my family name, Peg means just me, and it's not saying I'm one of a kind, but you know, pretty close. And so if you've got, if it's speciated, Pseudomonas aeruginosa, this is at the Pseudomonas stutzeri that's up there, then that is 2 separate species. However, if you've got an organism with different antimicrobial susceptibilities, such as methicillin-resistant staph versus methicillin-sensitive staph, that is still considered 1 organism. So let's practice that just a little bit. And so it's always good to have a piece of paper out when you're listening to these webinars to see what you think before I tell you the answer. So I'm going to put up 3 different urine cultures here, and you tell me whether these are cultures that you would be able to use as being positive urine cultures. I'll put all 3 of them up there and give you a minute to take a look at them and write yes or no. Okay, the first one, I think you can pretty quickly see there are 3 organisms listed, so that one would be thrown away. That would be considered contaminated. So that one should be a no. Number 2 has Candida albicans greater than 10 to the 5th and E. coli at 30,000 colony forming units. That one would not be considered either because there is a uropathogen there so far as the E. coli, but you can't consider the Candida albicans even though it is a large amount because your uropathogen, the E. coli, is not greater than 100,000, equal or greater than 100,000 colony forming units. So that would not be considered a positive urine culture either. However, number 3, even though it contains yeast, it has a uropathogen in the proteus, and the amount of bacteria in that urine specimen is greater than 100,000 units, so it would be used in your definition. So no, no, and yes. Okay, there's some key terms for used in NHSN that we need to understand so that when we're using the definitions, we use them correctly. And this is the list of them that we're going to go over. The first one is an infection window period. An infection window period was brought about in using surveillance definitions in 2015, and it helps you know whether, so that you are not looking through pages and pages of a chart for symptoms and cultures and trying to match them up. The infection window period is a 7-day period, and it is defined by the first diagnostic test, which when we're talking about UTI today, that's always going to be that positive urine culture that we just discussed. You look 3 days before it and 3 days after it for a symptom. So that's your infection window period, 7-day period, and it's always started with that positive urine culture to look for it. Okay, after you've got an infection window period, you need to look for what is a date of event. A date event is the first element used to meet the NHSN definition. It is really important to accurately define the date of event because it's also the basis for timing of all repeat infections. So the first element to meet the definition can be that culture, which started that infection window period, or it can be a sign or symptom. Present on admission is our next key definition. And present on admission is when that date of event that we just discussed occurs during that present on admission time frame. So when is that time frame? That time frame is defined as the day of admission to an inpatient location, which is considered calendar day 1, their admit date. It's also 2 days before the admission if there is in writing that they had some symptom. And it can't just be fever, it has to be fever of a certain degree. And it is also the present on admission time period also includes the calendar day after admission. So it can be 4 possible days. And you do not enter present on admission events into NHSN. So what is a healthcare associated infection then? A healthcare associated infection begins after that POA period is gone by. So you can't have a healthcare associated infection when we're talking about urinary tract infections until that 3rd calendar day. So these you do want to enter into NHSN, and those are the ones that we're most concerned about because those are the things we can do something about. Okay, repeat infection time frame is another important time period. Repeat infection time period is that 14-day time frame during which no new infections of the same type are reported. And so what begins that 14-day period is that date of event. So that's why I can't stress to you enough, accurately defining what your date of event is really critical so far as using these definitions correctly. If present on admission, that repeat infection time frame begins with the first day that they're admitted to the hospital, even if they say that they had there's a documentation of a fever 2 days before in a doctor's office or something like that. That's still day 1 is their admit date. So let's look at repeat infection time frame just a little bit closer. Why that's important is for 14 days from the date of event, there is not another infection of the same type that can be called. And so you won't have 2 CAUTIs during that time period. So what you do if you get another urine culture during that time period and it shows a different type of urine pathogen, you simply add that uropathogen to the previous event documentation of your UTI. You don't have 2 UTIs, you only have 1. So in this example, the uropathogen was E. coli on day 13. The date of event was actually day 11. And so when you get that urine culture on the 19th of Proteus, you simply just put that Proteus on the same event as the UTI with E. coli, and it's just 1 CAUTI that's counted in your infection control statistics. Secondary bloodstream infection is the last key definition, and we aren't going to talk too much about those today, but that's when you get a positive blood culture that they believe is secondary to that urinary tract infection, that urinary tract infection actually seeded the bloodstream and was the causative agent. It includes the time frame of the infection window period plus the repeat infection time frame, so it can be anywhere from 14 to 17 days. To have a secondary bloodstream infection, 1 organism must match. So you got to have a blood culture and a urine culture that matches. And it does not, again, include any of those excluded pathogens. So here's just a picture to kind of put it all together of those terms that we just talked about. Present on admission, any of those possibly 4 days. An HAI cannot begin until day 3. This is just a picture of a infection window period. It's a 7-day period, and it begins with the culture. You look 3 days before, 3 days after. A repeat infection time frame begins on the date of event and goes for 14 days. So let's move on to our CAUTI definitions. And how do we know what those CAUTI definitions are? Where's our resource? So on the NHSN website, on that same screen that has everything else about urinary tract infections, under the protocol tab, you will see, if you click on it, you will get the urinary tract infection event January 2020. If you open up that big PDF file, that is going to give you all the definitions that we're going to talk about. So there's your reference. There are 3 different types of CAUTI definitions, and we call them symptomatic UTIs. And so that's why it's SUTI and not CAUTI, because a SUTI can either be catheter associated or non-catheter associated. A symptomatic UTI number 2 is just with infants under 1 year of age. And then ABUTI stands for asymptomatic bloodstream urinary tract infection. And so we'll talk about what that definition is, and that can be of any age. So let's look at the very most common one out there, and that's SUTI, and it's a 1A. So it's the one where they have a symptomatic urinary tract infection and they do have a catheter in place. So we're going to break down this definition and define what you have to have in order to say that they meet the SUTI 1A criteria. So the patient must meet 1, 2, and 3 below. So let's look at the first section. Patient had an indwelling catheter that had been in place for more than 2 consecutive days in an inpatient location on the date of event and was either present for any portion of the calendar day on the date of event or removed the day before the date of event. Okay, so let's look at that just a little bit closer. So when we're talking about a catheter being removed, how do we know if it had been long enough? Remember, it has to be in 2 full days and removed on the date of event or the day before. So here's some examples. On the first example, the Foley's put in on day 1, it's there on day 2, the Foley in place for part of the day and then removed. The date of event was day 4, 1 day after the Foley had been removed. Would that one qualify for a CAUTI definition? Yes, it would, because it was removed on the day after the day before the date of event. The second example here, Foley placed on day 1, removed on day 2, no Foley day 3, and then there's the date of event. There was a whole day there that the Foley was not in place, so that one would not qualify to be used for a CAUTI definition. Okay, our third example, Foley's placed, Foley's in place for part of the day, then removed, then there's a date of event. Could that be a CAUTI? No, that one can't be a CAUTI either, because remember, it has to be in 2 full days before it can be considered. So there's 3 scenarios for you. So let's look at this for just a minute and practice. On October 5th, a patient had an extensive vaginal bladder repair with the catheter inserted. On the 8th, 3 days later, in the morning, a catheter is removed. The very next day, the patient was unable to avoid and was very uncomfortable. The catheter was reinserted that afternoon. So on 10/10, when you're looking at whether has the catheter been in 2 days, or would you count it as 6 days that it had been in continuous from 10/5? So why don't you think about that for a minute? Would this be considered in 2 days or 6 days? Okay, I put up this scenario because 6 is the correct number. The catheter was not out 1 full calendar day. And I want to make sure you realize that that is not to be read as 24 hours. See, in the scenario, it was taken out on 10/8 in the morning, and 10/9, the catheter was reinserted in the afternoon. That's more than 24 hours. And that's a common mistake that's made. It's full calendar day, not 24 hours. Okay, and here's just another little scenario to reinforce that. Patient admitted, catheter inserted. Day 4, it's removed, replaced on day 5. Date of event is day 6. Can this be catheter associated? Yes, it's the day before the day of event. Another one, you can see when you map them out. Day 1, it was placed, removed on the 4th, out the whole calendar day of the 5th. Day 6, it was replaced. The date of event is 7. So there was 1 full calendar day that it was out. So this would not be able to be catheter associated. That's why mapping these things out really will help you in using definitions correctly. Okay, we talked about our must-haves for CAUTI and practiced a few of those scenarios a little bit. Catheter through the urethra, left in place, connected to a drainage bag, in place for 2 days, and you have to have a positive urine culture. We've talked about all those different things. Now we get to the part that symptoms matter, and they matter a lot. And when we're looking at the definitions, you can tell which symptoms and some extra things about those symptoms. There'll be an asterisk by it or a little carrot looking figure. And I wanted to draw attention to those because those really make a difference. Some of those nuances, it's like reading these definitions, and whether it says and or, all that stuff really makes a difference. So we talked about number 1. Now we're going to talk about that second section. Patient has at least one of the following signs or symptoms: fever, suprapubic tenderness, costovertebral angle pain and tenderness. And note that fever, there's no extra criteria there. Suprapubic tenderness and costovertebral angle pain and tenderness have an asterisk by it. And then the last 3, urgency, frequency, and dysuria, have that little carrot by them. So those are critical to remember. Symptoms matter. Let's talk about fever. Fever is a non-specific symptom and cannot be excluded from your determination just because you think there's another cause of that that fever. If they've got terrible pneumonia or a great big surgical site infection or wound that is really infected, you can't say, well, the fever's from that. In using the UTI surveillance definition, if that fever is greater than 100.4, you have to use that symptom as part of your definition. And then the other thing that I want to draw your attention to is it's greater than 100.4. This is the most common mistake I find in using these definitions. So the patient's temperature actually has to be 100.5 in order to be used in the definition, because it's greater than 100.4. The other thing that is very specific about fever, to use fever in a patient greater than 65 years of age, and this kind of falls in line just like that fever, so it has to be a patient who is 66 years of age, not 65, in order to use this part of the definition. To use fever in a patient greater than 65 years of age, the catheter has to be in more than 2 consecutive days in an inpatient location on the date of event and still in place or removed the day before the date of event. So we're going to look at that a little bit closer. We'll practice that a little bit. So what that's saying is the catheter has to be in at least 2 days prior to the date of event in order to be counted. And why is that? It's because in the older adult, non-catheterized patient who has a fever but no other signs for a UTI, usually there's another cause in 90% of the cases. So that's why they don't allow it to be used on those greater than 65. Okay, what's another symptom? Suprapubic tenderness. And remember, that's if there's no other cause. That has that asterisk by it. And so remember, suprapubic tenderness, it doesn't, you aren't going to have a patient that says, oh, I have suprapubic tenderness. No, usually that's elicited by palpation. You press on the lower abdomen of a person and they squirm, they do express some sign of pain, and that would be positive. It doesn't have to be a verbal type of thing. It can't just say lower abdominal pain, and it really needs to be defined as, it needs to be more than just generalized abdominal pain, because there's too many reasons for that. It really needs to be more localized and saying lower abdominal pain or pelvic discomfort in the documentation. And these are things that need to be documented, because it needs to be that if I would come in and validate you, I could see exactly what you were talking about in that symptom being there. Okay, our next symptom is costovertebral angle pain. That is left or right pain. The back or flank pain are things that you qualify as this. Generalized low back pain is not to be interpreted as costovertebral angle pain. It must be lateralizing one side or the other. Okay, and then as you see, the ones with the catheter in place, those are the symptoms that you can use. And then you can add frequency, urgency, or dysuria only if the catheter has been removed. So let's practice what we just went over so far as symptoms. So let's look at this. A patient was admitted on March 25th and for trauma. They have a catheter in place on the 26th. And on the 27th, they were moved from ICU to 3 South. On 28th, the next day, it was discontinued early in the morning, and at noon, they complained of frequency. No fever on the 29th. The 30th had elevated white count, and on the 31st, they had a positive urine culture with E. coli. Can you use frequency as a symptom here? What did we say about frequency? We said it can only be used when the catheter has been removed. So let's look at this. It really helps, again, to map out these situations. So is it meeting our criteria? They had a urinary catheter inserted, it was in greater than 2 days, it had the positive urine culture, so then we have to look for a symptom within our infection window period. So our infection window period begins with the urine culture. You look 3 days before and 3 days after. So our urine culture is on the 31st. You can see where that star is. And so we look 3 days before. Frequency is within the infection window period. So check that off. That's one thing that shows that, first of all, it has to be within that infection window period. That is there. But frequency can only be used if the catheter has been removed. Well, in this situation, the patient's complaint did come after the catheter had been removed. However, would it still be considered catheter associated? So let's look at that. A UTI with the event date on the day of discontinuation. So the date of event would be then that date that they complained of the symptom. And that's also the date that the device is discontinued. So that would be considered a catheter-associated UTI. Even though the symptom was when the catheter was removed, it was on the date of event and it met all the other criteria. You're gonna have trouble entering that into the database, and that's why I use this scenario, because this is a screenshot of an entry of an infection into the NHSN database. And when you look at this, under risk factors, I got a red circle around there. It says urinary catheter, and you would put in place for it because it met that definition. It was removed on the day of the date of event. So it would be considered an in-place catheter. You're going to get an alert that comes up and you're going to think, oh my goodness, I did something wrong. Well, you didn't do anything wrong. This is just a reminder that you can only use those symptoms whenever a catheter is removed. In your documentation, that frequency occurred after the catheter is removed. It will still allow you to enter this case. You just say, okay, yep, I know that, but this did happen this way. You would still mark frequency as your symptom and enter it as you would before. Okay, assigning the correct location to this. Remember, our patient was transferred from ICU from ICU to 3 South. Okay, the date of event was on the 28th, the day after they moved from ICU to 3 South. So you want to make sure, and believe me, the nursing staff usually gets pretty upset if you try to attribute an infection to their location when they don't believe that they had a part and don't want to own that infection. So this patient was transferred the day after, on the 28th, the day that it was determined. Okay, so what are our transfer rules? So is it ICU or is it 3 South? So our answer is, if the date of event for the UTI is the day of transfer or the next day, the UTI is attributed to the transferring location. So what is the transferring location? ICU. And this is the same rule for discharge. If the date of event is the day of discharge or the next day, the infection is attributed to the discharging location. So, as I said before, is it ICU or 3 South? Using this definition, it's ICU. It was the day after they had transferred. Now there is one thing, sometimes especially in larger hospitals, or you may have someone who goes to multiple locations on one day. If they do that, if they are assigned multiple locations on one day, it is always the first location that they were at. Okay, and I'll just mention the non-catheter associated criteria because this still should be in your infection control statistics on any infection that occurs. And see, the difference is that, you know, it had not been in place and did not have a urinary catheter on the date of event or the day before, the use of the symptoms, and a positive urine. Okay, SUTI type 2. Remember, that's a catheter-associated UTI for patients 1 year of age or less. What is different about this? It can be with or without an indwelling urinary catheter, but the big difference is symptom-wise. For a baby, a big symptom for them is hypothermia. Hypothermia is like fever. It is a non-specific, considered a non-specific symptom. So you don't see any asterisks or any carets by that. If they have hypothermia, it must be attributed to a urinary tract infection if they meet the rest of the criteria. But then the number 3, the urine culture, you look at it just the same. And here's the criteria for that one that I mentioned before, the asymptomatic bacteremic urinary tract infection. They have to have with or without an indwelling catheter, just like SUTI 2. They have to have a urine culture with no more than 2 species, 100,000 colony forming units, but then they have to, the big difference is that one matching blood culture to the urine culture. And remember that a booty is reportable if catheter associated, so that does need to go into the NHSN database. So let's do some practice here while we've got some time left. And here's a 68-year-old patient admitted for an MI, central line and urinary catheter inserted after an episode of severe hypotension. For 3 days there, no signs or symptoms. On the 24th, they have a positive blood culture. They just did pan cultures on the 24th because they had an elevated white count. We're looking a little septic. They get a positive blood culture of staph, positive urine culture of staph. On the 28th, they removed the catheter, they seemed better, and they were discharged home. Is there anything to report here? Did this patient have those things that we've just talked about? Did they have a SUTI 1, SUTI 1B, SUTI 2, a booty, or none of the above? Well, we can definitely cross out SUTI 2 real quick because they're certainly more than 1 year of age. They're 68 years old. Okay, and we look at the rest, SUTI 1B requires you not to have a catheter. Did this person have a catheter? Yes, they did, the full time. So those 2 we can knock out real quick. SUTI 1A, we have to have a symptom. It has to be fever. It has to be Costovertebral or suprapubic tenderness with that catheter in. Do they have any of those? No. So, but what we do have on the 24th, a matching blood culture, matching urine culture. And so this person and a booty should be reported. So process to investigate a positive culture. Do they have those must-haves that we've talked about before? Look at what that infection window period is, that 7-day period, and then look for a symptom during that time. If all the criteria fit with that infection window period, is there an actual event? If yes, continue. If not, stop. You got better things to do with your day. If you do believe there's an event, then you need to determine that date of event to determine whether it is present on admission or healthcare associated. And then you need to know who to attribute it, the location to attribute to. And if it is present on admission, you don't go any further. Otherwise, you do attribute it to a location and then determine the repeat infection time frame. One thing I do need to say here, though, so that a presence on admission UTI does start a repeat infection time frame, though. Map it out. I can't say that enough. On the NHSN website, there are resources for users. So under that same screen I showed you before, there's a tab that says Worksheet Generator. And if you click on that, it will give you the screen on the right there. And there are both. You can click on the top one, the worksheet for denominator data, and it will give you a manual worksheet. And then there is also now an electronic worksheet that you can use. So this is what the manual worksheet looks like, and this is what the electronic worksheet does for you to use. So it's very easy and kind of fun to play around with. You put in the admission date, you put in that first diagnostic test, it will map out the infection window period for you, and it will map out your repeat infection time frame. It's really nice. So let's do some practices before we end the day. 65-year-old male admitted to 3 West for total knee replacement, indwelling catheter placed preoperatively. Day 2, temp of 100.5. Urine culture E. coli is, answer the following questions. Is this a CAUTI? And if yes, is it HAI? Is it healthcare associated, or is it presence on admission? Okay, let's look at that. Look at our must-haves. Indwelling catheter. Was it in for 2 days? Do they have a positive urine culture? Do they have a symptom? Okay, they're 65 years old. We need to look at that age. We need to look for that symptom. Remember, it's greater than 100.4 on fever. This is 100.5, so that works. Urine culture, E. coli of a significant amount, and it is a uropathogen, so that works too. Okay, so we do have a urinary tract infection. Now, is it catheter associated? Is the question, and if so, is it HAI or POA? And so in this particular person, with the date of event being what? Day 2, because that's when the symptom occurred, this would be a present on admission event. Okay, on day 4, this person was transferred to your inpatient rehabilitation facility. Just in another wing of your facility, not a separate facility, but in your hospital. They have another temp, 100.5, and they do another urine culture with staff. Is this now a catheter-associated urinary tract infection or a second CAUTI? And if so, what is the date of event? Okay, first of all, they are 65 years of age, so you can use that temperature as a symptom. So that's where your date of event is going to be. You have a 14-day repeat infection time period from that date. So this is present on admission, but that Staph aureus, if that falls within that 14-day time period, it does. So this is not a second catheter-associated UTI. That Staph aureus is added to the present on admission urinary tract infection. So let's look at a picture of that. It helps to really define if there is a SUTI, there is a non-catheter associated, you've got the temp on day 2, you've got urine culture on day 3, date of event is day 2, repeat infection time frame, and so that is added to the previous one. And it's POA because you can see it's on day 2. And that transfer makes no difference. Okay, another practice. Patient is admitted December 3rd, 75 years old for CVA, fully inserted, On the 5th, temp 100.4. Urine culture collected and reads Pseudomonas. Is this a CAUTI? What's missing there in your mind? Well, that temp is 100.4. That's probably the biggest thing. December 11th, 100.6. Is this a CAUTI? And if so, what is the date of event? So let's look at it mapped out here a little bit. You've got infection window time period beginning on the 9th, 3 days before, 3 days after. So do we have a CAUTI? We have a symptom within the infection window period, and we have a positive urine culture of a uropathogen. The date of event would be the date of the culture on the 9th, and that would establish your repeat infection time frame. So let's go a little bit further. We said what the date of event was the date of the culture, 12/9. So this patient on December 14th is now changed to a swing bed patient. Urine culture is collected and reported as E. coli, 100,000 colony forming units. Isn't this new, or is it a repeat infection? Let's look at that picture, mapped out. The transferred on the 14th. And E. coli on the 17th. If they are in the same location in your facility, even though now they're a swing bed patient, because I know a lot of you work that way, that E. coli would just be added to the Pseudomonas UTI, and it would be one UTI. Let's do another one. December 16th, 75 years old, admitted from a local nursing home with an catheter in place, temps 102. She had been discharged from your facility on the 15th. Blood culture, urine cultures are done. Both show staph. Does this meet the requirement? If so, is this HAI or POA? Or say I should have put catheter associated UTI, not a SUTI 1A. Okay, the fact that she was discharged from your facility the day before, that would count to you. So this would be healthcare associated in your investigation because they were gone the day before. It wouldn't be present on admission. So that brings up that question, should I be doing, I get this a lot, and that's why I wanted to address this today. Should I be doing a urine culture on everybody who comes in with a catheter? I want to really encourage you not to do that. And there's a lot of reasons not to do it, besides the waste of the healthcare dollar. But they have no symptoms in this example, so there's no repeat infection time frame. So that they have another positive culture when they haven't had a symptom, there isn't a repeat infection time frame. So it wouldn't be, it would still be called CAUTI. So in this example, they had a urine culture done several days later, and they have a fever. Since there's no repeat infection time frame, this would still be called caused a CAUTI. Treating, because what happens, you get back a positive culture and we can't stand it. We have to treat it. And what we're treating is asymptomatic bacteriuria. There's biofilm around that catheter, and that's what you would be treating. So resources in order to get these definitions right. This is a lot of information in a short period of time. There's some excellent checklists. They have just been updated on the NHSN website. On the left-hand side, there is one that says HAI checklist. I know that's real small on the screen. And it'll say a checklist for UTI, and it will give you a worksheet with check boxes to go through the things that we've talked about. I want to encourage you, if you do recognize the UTI, to use this event form for your records. This is a form that's on the website too that you don't have to make up, and that will give you a good past history of what has happened with your patients. And it's an excellent tool to take you to your infection control meetings to discuss what can be done to prevent urinary tract infections. So in summary, we need to recognize the must-haves for CAUTI. We got to identify those key terms. It's really critical that we use surveillance definitions, because these are our baselines in order for quality improvement. And for some of you, pay for performance programs. It really decreases the subjectivity and makes it much more reliable that you know what's going on. And measuring your CAUTI rates will help you be successful and prevent them. If you don't measure them, you won't know what you have. And with that, I'll take any few questions. I know I didn't end up leaving very much time for questions. If I don't get them all answered today, I'd be glad if Dana gathers any questions you had. I'd be glad to answer them by email, if that's the case. So if you want to open up the lines, I'd take a few questions while we have the time.
Okay, I opened everybody's lines. If you have questions, go ahead. Otherwise, if you do need to hop off at one, go ahead and shoot me an email and I will move it along to Peg and we can go that way, or you have her connection there too.
I have a question. We have a portion of our hospital, we have what we call private pay, and it's people, elderly people that live here, so kind of like a nursing home. How do we consider those when it comes to hospital acquired versus not?
Those that are in a intermediate or a skilled wing of your facility are not considered acute care inpatients. So you can enroll that part of your facility as a long-term care facility, and there are different definitions, and that should be kept separate. Simply, you know, when we talk about this, we're talking about risk. So usually that's different equipment, different environment, and so what you can do to change things is different. So that should be kept separately.
Okay,
now,
where can I go to get those guidelines?
Same place. At cdc.gov/NHSN. And so the next screen, rather than you looking at the acute care hospital definitions, there is a box to click on for long-term care.
Okay, thank you.
Mm-hmm. They are different, especially for this. There's no infection window period, several different things.
Okay.
But there are some similarities, the two organisms in a urine culture and things like that.
Okay. But the reporting still stays the same. If it is a true hospital acquired, it does still get reported.
Yes, absolutely. Okay. If one of those residents would move over to your inpatient location, then they become an inpatient. Now, if you've got a person on your inpatient location and you change them to a swing bed person, they are still considered an inpatient. They have the same risks. They still only
Okay.
move back to their other wing.
Okay.
Good question.
Peg, this is Dana. There was one question written in. I don't know if you can see the chat or if you'd like me to read it to you.
I'd need you to read it to me. I do not see it.
Okay, so when you are counting catheter days at the beginning of your slides 2 through 6, how would you handle someone counting at 7 a.m. and the catheter was removed at 5? I do not count those as catheter days since it was not present at the 7 a.m. count. Can you elaborate?
Yep, that is correct. Because one of the criteria that NHSN has for counting catheter days is it has to be at the same time every day. And that's on slide 4, count at the same time each day, and what you're doing is correct.
Great, thank you. Any other questions out there? Okay, well, we will wrap up then. Peg, thank you so much for your wonderful information as usual. And if I hear anything as far as questions go, I'll pass those along to you. And we look forward to next week, our second webinar from you about NHSN. So thanks a lot, and thanks everybody for joining us today.
Thank you.